Volume should it on? Very good morning, everyone. Sorry, good afternoon, and sorry for the delay. And we also could not do our sessions last couple of weeks because of the festival season. So we are back with the next issue of next webinar of Cuddles online neonatology lectures. And today we are going to discuss few OSCEs on neonatal nutrition. So I'll begin with the first few questions, which are true or false questions. So the first question is, milk protein content is not related to maternal diet, but increases with maternal body mass index. So is this true? Answer is yes, this is true. So milk protein content, as you know, in a term baby is around 1 to 1.1 grams per deciliter. In preterm EBM, the protein content varies between 1.5 to 2 or up to 2 to 2.2 grams per deciliter, especially in the first 2 weeks after preterm delivery. This is not related to maternal diet, but it might increase with the maternal body mass index, and hence there are some constitutional variations in breast milk protein content across population. The next question is, human milk contains 82% casein and 18% whey protein. This is obviously false. You all know that human milk contains predominantly whey protein. Whey protein accounts for 80% of the human milk protein, and casein accounts for only around 20%. So this is actually it's a complete inverse of the truth. Now, whey protein, as you all know, lactalbumin and lactoglobulin has numerous beneficial properties, including immunological benefits to the baby. The next question is, a mother with active miliary tuberculosis who has already received ATT for 1 week can give direct breastfeeding. Although we say that a mother with tuberculosis can generally give breastfeeding after the ATT has been started, usually one waits for at least 2 weeks of completion of anti-tubercular therapy, or after the sputum smears are negative for Mycobacterium tuberculosis. So this mother having active miliary tuberculosis, one should ideally wait for at least 2 weeks of proper anti-tubercular therapy, and it is important to document that her sputum was negative for AFP before we start direct breastfeeding. However, expressed breast milk can be given safely after taking appropriate contact precautions. So this statement is false. The next question is, the incidence of SIDS was lower in exclusive breastfed babies, but statistically not significant. This again is false. Breastfeeding reduces the chances of UTI. Now, although breastfeeding has been found to reduce the incidence of number of infections like serous otitis media, pneumonia, and acute gastroenteritis, it is not found to significantly reduce the incidence of urinary tract infections. So this is false. Next, we move on to the next OSCE. So these are some numericals. What is the fat content of mature human preterm milk per 100 ml? So the fat content of mature human preterm milk is roughly around 3.6 grams per 100 ml. Next question is, sodium content of mature preterm human milk. This is 0.9 milliequivalents per 100 ml. So sodium, protein, and chloride are some components which are constitutionally higher in preterm breast milk when compared to term breast milk. This is probably a physiological adaptation to the increased demand in the baby. So protein, again, as we discussed, is higher in preterm EBM, starting from around as high as 2 to 2.2 grams per 100 ml in the first couple of weeks following preterm birth, and gradually coming down to around 1.5 to 1.8 grams per deciliter after the completion of the first 2 weeks. Calcium content of preterm milk per 100 ml. Calcium, one needs to remember, both in term and preterm EBM is not very high. In fact, it is much lower in preterm EBM compared to term expressed breast milk. In preterm milk, the calcium content can vary between 25 to 30 milligrams per 100 ml, whereas in term milk, it is around 30 to 35 milligrams per 100 ml. Next question is about Lactodex human milk fortifier. So you know that there are multiple multi-component fortifiers available now in the market. We declare no that we don't have any conflicts of interest, but there are multiple brands. We have Lactodex HMF, which is from Raptocos. We have Pre-Nan HMF from Nestle, and we also have Advanced HMF. And some parts of the country also have Hijam HMF. Now, protein content in these fortifiers is pretty variable. Now, in the standard Lactodex HMF, the protein content in 1 gram sachet is 0.27 grams. The calorie content is also something that is commonly asked. In each sachet, the calorie content is roughly 3.3 kilocals per sachet. So when we add human milk fortifier to express breast milk, usually the standard preparation is to add 4 grams to 100 ml. So this increases the protein content of breast milk by 0.27 into 4, which yields around 1.1 grams of additional protein to 100 ml of fortified milk. Iron content of Lactodex HMF again is important. 0.3 milligrams per gram is the iron content of Lactodex HMF. Unlike the earlier preparations of HMF, which contain much lesser iron, the newer preparations of Lactodex human milk fortifier contained a little higher content of iron. So the Espegan recommends 2 to 3 milligrams per kilograms per day prophylactically iron supplementation for preterm very low birth weight neonates, and most of this requirement is met by fortified EPA. So we move on to the third OSCE on nutrition. Uh, this is mostly about human milk banking. So in which year was the first human milk bank of India established? So this was established in the year 1989, and this was set up by Dr. Amira Fernandez in Mumbai. This was the first human milk bank. However, following this, a lot of improvement has, lot of progress has been made. In Hyderabad, we all know that Datri Milk Bank is one of the biggest human milk banks operating at Nilofer Children's Hospital in Hyderabad. A lot of corporate hospitals also have initiated their own human milk banks. Now, what is the minimum requirement in terms of space required to establish milk bank? The space required is actually not much. All we need is 250 square feet. This is the minimum area required for establishing milk bank. Next question is, what is the temperature and duration of the Holder's method of pasteurization, which is used for human milk banking? The temperature that is required is 62.5 degrees as per Holder's method of pasteurization, and the holding period must be at least 30 minutes, followed by rapid cooling. The other methods of heating, which are generally used in pasteurization, are the flash method, high temperature short time, and we also have ultra high temperature short time technique. So apart from pasteurization, there are other methods of sterilization which include ultraviolet C radiation and high pressure processing. So these are other methods of human donor milk processing in milk bank, but Holder's method, which is heating till 62.5 degrees and for 30 minutes followed by cooling, is the most popular method. Okay, now the next question is, what is the milk flow process in a milk bank? So milk that is initially expressed by eligible screened donor mothers is stored in sterile containers, followed by thawing once, because storage is usually done in the refrigerator. Then it is subjected to pasteurization. Pasteurization is usually done in cycles of based on the capacity of the bottles used. We have 250 ml bottles, we have 125 ml bottles, and we have pasteurizers that can accommodate up to 12 bottles, sometimes more. So that many liters of human milk then undergoes pasteurization, following which cultures are sent, post-pasteurization cultures. Then it might be again stored in the deep freezer based on the time that is sort of the time that is required before the milk is required for dispensing. Post cultures, if the milk is found to be sterile, then we start dispensing the milk. Camera నేను ఆఫ్ చేశాను. Switch it on. So I repeat, the steps in milk flow are milk expression, followed by storage, followed by thawing, and then pasteurization, following which there is storage in the deep freezer, and post cultures coming sterile, the milk is considered eligible for dispensing. Just before dispensing, thawing is done and milk is dispensed. So once thawed, after pasteurization, milk is not supposed to be refrozen. The next question is about some important components of breast milk, and we are going to discuss about their roles. First is secretory IgA. So IgA is a specific antigen targeted anti-infective immunoglobulin. So secretory IgA is supposed to protect the baby from infections, particularly gastrointestinal infections, and this is usually antigen specific. The next molecule is oligosaccharides. Oligosaccharides are also known as HMOs, human milk oligosaccharides, represent a complex and diverse group of non-digestible um, polysaccharides, basically. So these are carbohydrate driven non-digestible carbohydrates, which serve as nutritive moieties for the commensal or the beneficial bacteria, particularly lactobacillus and bifidobacterium. So these molecules which are present in human milk stimulate the growth of the beneficial or the favorable bacteria. And they also stimulate the production of short chain fatty acids in the intestines, leading to a more acidic pH, which in turn leads to the death of the pathogenic bacteria. So overall, these are prebiotics. These are non-digestible carbohydrates, polysaccharides, and some examples being LNNT and fucosyl lactose, fucosyl the silylic acid, etc. These are molecules that, when provided at the right quantity, stimulate the growth of beneficial bacteria such as lactobacilli and bifidobacterium. Then comes leptin. Leptin is a molecule that regulates the infant's appetite and BMI. Nucleotides are also present in breast milk, which enhance the antibody response to various pathogenic bacteria. Then we have glutamine, which is an amino acid, and this serves as intestinal fuel and again modulates immune responses. Next OSCE is about preterm nutrition. So we are dealing with a 10-day-old, 28 weeks baby with a birth weight of 1000 grams. This baby is receiving 3 gram per kg of amino acid and 3 gram per kg of lipid with dextrose infusion of 6 milligram per kg per minute. So given these values, what is the formula to calculate the calorie nitrogen ratio in this case? So we have two components in the parenteral nutrition. One is calorie protein ratio and the other is calorie to nitrogen ratio. Now, while we calculate the numerator, which is the total calories provided, we generally calculate carbohydrates from the fat and carbohydrates from the um, dextrose. Usually, it is not a good practice to calculate the carbohydrates from the amino acids, which are produced by gluconeogenesis, because that is not the primary purpose of providing amino acid. So in this example, we are giving 3 gram per kg of lipid, so which translates into 9 kilocals per every gram. So 3 into 9 from lipid. Then we have dextrose infusion of 6 milligram per kg per minute. So this in turn translates into 6 multiplied by 60 minutes every hour multiplied by 24 hours. So this gives actually 8.6 grams of dextrose in the whole day. And this is multiplied by 3.4 kilocals, which is provided by each gram of dextrose. So we have 8.6 into 3.4 calories provided from the dextrose component, which translates into 29 kilocals, and 9 into 3 from the fat component, which is again 27. So this is represents the numerator, and this is divided by 3, which is the total amount of grams per kilograms of protein. So this actually represents the calorie protein ratio. But since they are asking us to calculate calorie nitrogen ratio, we multiply the numerator into 6.25. So in this example, it comes to 117.1 kilocals per each gram of nitrogen. How much should this be? Ideally, the calorie nitrogen ratio should be somewhere between 150 to 250. Calorie protein ratio should be somewhere between 25 to 32. Okay, next question is, what is the benefit of using 20% lipid over 10% lipid in total parenteral nutrition? So the important benefit is the higher ratio of phospholipid to triglyceride in the 10% emulsion may interfere with plasma triglyceride clearance, leading to hypertriglyceridemia with 10% intralipid solution. So 20% is preferred, and 20% also has more concentrated form of energy. Next question is, what is the advantage of SMOF lipid? So you all know that lipid infusion is available as SMOF or intralipid in India. There is another preparation called Omega Win, which is not available here. Of this, SMOF represents the combination of soya, MCT, olive, and fish oil. So SMOF lipid is supposedly believed to contain more omega-3 polyunsaturated fatty acids and is associated with lesser chance of sepsis, cholestasis, and inflammation. So it is believed to cause lesser parenteral nutrition associated cholestasis or can reverse TPN associated cholestasis to a major extent. Next question, which are the trace elements that are to be avoided in cholestasis? The true trace elements that are to be definitely avoided are copper and manganese. And the trace element that needs to be started from day one of TPN is zinc. Okay, next question again is true or false. So these true or false are the following. Human milk oligosaccharides are reduced after pasteurization. So is this true? Now, human milk oligosaccharides are grossly unchanged with pasteurization. So the answer is false. What is definitely reduced is protein. So proteins tend to get reduced. They also may tend to get hydrolyzed to smaller forms like peptides. So proteins are reduced, that is true. Prolonged use of donor human milk failure can lead to growth failure. So this is again true. So prolonged use of donor human milk because of its the reduction in the calorie as well as protein content can be associated with growth failure. This is also a reason why preterm infants who are fed donor human milk also should receive fortification. Next question is, donor human milk has no effect on immunonutrients. This is false. In fact, the favorable effect on providing appropriate immune modulation is one of the important benefits of giving donor human milk. LC-PUFA in donor human milk is preserved. This is also true. So surprisingly, the long-chain polyunsaturated fatty acids are not really removed by pasteurization. Next question. So what are the benefits of breast milk on the following conditions? So we are supposed to provide evidence. Severe ROP, breast milk is definitely found to reduce severe ROP by almost 90%. NEC, yes, again, the consumption of breast milk has been found to not only reduce NEC, but it also has a dose benefit effect on reducing necrotizing enterocolitis. So overall effect on reducing NEC is by around 83%. Next comes BPD. Again, probably because of the anti-inflammatory effects and the provision of anti-inflammatory molecules like LC-PUFA, the use of breast milk is associated with a lesser risk of developing BPD, and this is by around 26%. The relative risk is 0.74 with breast milk for developing BPD. SITS, yes, breast milk is associated with a statistically significant reduction in the risk of SITS, sudden infant death. The odds ratio is 0.27. So it's around 73% lower risk of developing SITS. And what is the effect of breast milk on the IQ of the child? We all know IQ of breastfed babies is better than the IQ of formula fed babies, and the difference is again a standard mean difference or weighted mean difference of 3.4 points. So it means the use of breast milk is associated with 3.4 point IQ greater among breastfed children. Now, this is the next question. Okay, a 26 weeks baby initially who had RDS and was managed with surfactant and invasive ventilation for 14 days is now 36 weeks of gestation and baby is on low flow oxygen requirement. After 7 days, the baby has swelling over the left upper arm. So what is the left upper arm showing in the X-ray? There is a fracture of the humerus. So this is obviously because of metabolic bone disease. So what is this? This is metabolic bone disease with humerus fracture. So as per the KOOS scoring, this qualifies for grade 3 metabolic bone disease. You know the grade 1 is the presence of rarefaction of bones or presence of osteopenia. Grade 2 is the presence of rarefaction associated with metaphyseal alterations like subperiosteal bone formation or metaphyseal shadows. Grade 3 is the presence of fractures in osteopenia of prematurity. So this is KOOS scoring, and this baby has grade 3 osteopenia as per KOOS scoring. What are the biochemical diagnostic criteria for OOP or metabolic bone disease? Biochemical parameters are the presence of low phosphorus levels. Usually the cutoff for low phosphorus is lower than around 3.6 milligrams per deciliter or 1.16 millimoles per liter, and the presence of elevated alkaline phosphatase levels. So alkaline phosphatase levels, some would say more than 900, some would say more than 1000 units per liter is indicative of osteopenia of prematurity. What is the investigation of choice? Now, although biochemical parameters or X-ray may pick up metabolic bone disease, they are not sensitive and they are not useful in the early stages of metabolic bone disease, particularly X-ray. In order to pick up grade 3 changes, it is said that 80% of bone demineralization must have already occurred. Likewise, the biochemical changes like low serum phosphorus and elevated ALP are also not sensitive for the early diagnosis of metabolic bone disease. Hence, we may have to actually perform DEXA, which is dual energy absorptiometry, X-ray absorptiometry. Again, DEXA has a quantitative and a qualitative assessment for metabolic bone disease. These days, ultrasound diagnosed speed of sound or SOS is also being evaluated for the diagnosis of osteopenia of prematurity. So how do we manage this condition? This condition is managed by optimizing the intake of minerals. Minerals refers to calcium and phosphorus, of course. So as per the ESPGHAN 2022 guidelines, one is supposed to provide 120 to 200 milligrams per kg per day of calcium and roughly 50% of this intake as phosphorus. The AAP, on the other hand, recommends 150 to 220 milligrams per kg per day of enteral calcium and roughly 75 to 140 milligrams per kg of elemental phosphorus. And this needs to be complemented with an optimal intake of vitamin D, which is for 400 to 700 international units per day, units per kg per day as per the ESPGHAN guidelines. What is LAT score? What are the components of LAT score? Now, LAT score is one of the common systematic assessment methods for the assessment of breastfeeding latching. So this implies it's L for latch, A for audible swallowing, T for the type of nipple, C for comfort, whether there is any breast or nipple pain or discomfort, and H for hold. The utility of LAT score is that it assigns the kind of key priority points for those providing breastfeeding assistance for mothers. And those who are having lower scores, obviously they require more support. So it gives you an objective way of assessment of the breastfeeding comfort assessment. So if somebody has a score of more than 6, then it suggests reasonably good breastfeeding skills. The next OSCE, the 28-weeker preterm baby weighing 1000 grams is admitted in the NICU with RDS and the baby is started on IV fluids as well as respiratory support. The baby is given 1 dose of surfactant, is maintaining saturations. So would you like to start trophic feeding? When would you like to start trophic feeding? Now, as per most of the standard guidelines, trophic feeding or minimal enteral nutrition is to be started as early as possible and definitely within 24 hours. What are the benefits of trophic feeds or minimal enteral nutrition? Definitely, it is found to be associated with lesser time for reaching full feeds, reduced duration of total parental nutrition, and shorter hospital stay. Now, how rapidly can we scale up feeds or grade up feeds? Scaling up, escalating feeds can be done at a speed of 20 to 30 ml per kg per day. The study does show that escalation at 30 ml per kg per day is safe. When to use 45 feeds? Although standard recommendations were to start fortification at a volume of 100 ml per kg per day, newer guidelines recommend that fortification can be started from as early as 60 to 80 ml per kg per day. Now, what are the definite signs to stop feeding and keep the baby NBM? Definite signs of feeding intolerance are the presence of bilious vomiting, the presence of severe abdominal tenderness, blood in the stool or blood in the OG tube, and a baby who is having tense and tender abdomen. The mere presence of gastric residues or increase in girth by more than 2 centimeters would not be a definite criteria to stop feeding, although you would go back and reassess the baby's abdomen for the presence of the other signs that we discussed. So we will stop here and discuss the other 10 OSCEs in the subsequent session. Thank you all for joining us today, and thank you for bearing with us for the delay in starting today's session. See you all next week again.